Hello, let's discuss the prostate. Questions that you will encounter on boards involving the prostate will be as much about diagnosis as they are about treatment and medical decision making. And that's because the prostate's pretty easy to diagnose. You could have an infection of the prostate that's called prostatitis. You could have benign prostatic hyperplasia, which is a very common condition going to present with some dysuria. And then you could have prostate cancer. And that's about it. So, because sometime a decade or so, a couple decades, 3 decades back, we started screening everyone and their uncles for prostate cancer. What happened was we ended up catching a lot of prostate cancers very early on. But the thing is, many prostate cancers progress gradually, and some don't even scratch a person. You can live forever with prostate cancer and die of completely unrelated causes. And so we were catching these prostate cancers and treating them, and we looked back retrospectively and realized, man, we're throwing a lot of money at this, seemingly for very marginal benefit. And so they want to test you and me, future clinicians, about how are we going to handle various findings in patients with prostatic disease, because that can generate a lot of savings in the medical system if we can manage prostatic disease correctly, or just refer it to a urologist, and let those guys do it. So let's dig into this first SDL. Prostatitis is inflammation of the prostatitis. There's an immune response to an antigen or some sort of stimulus. Now, kind of a decision tree with 2 branch points here. First of all, you can have acute or chronic prostatitis, and that's easy. And then second of all, you can have bacterial or non-bacterial prostatitis, and that's pretty also easy, provided you just get the culture correctly. So this is not a diagnosis of symptoms. This is a lab diagnosis. And histologically, acute versus chronic is just neutrophils versus lymphocytes. You understand that. The major prostatitis, 9 out of 10 cases, is this non-bacterial chronic prostatitis, which is also called CPPS, chronic pelvic pain syndrome. We get into the different categories. Acute prostatitis is almost always bacterial in origin, very rarely viral or fungal. Typically a sequelae to a UTI or a sexually transmitted disease. I don't want you to forget things like chlamydia. Chlamydia trachomatis is a very common cause of prostatitis, and Neisseria gonorrhea can also cause that. So remember about those 2 bugs. Neisseria is a diplococcus, it's gram-negative, and chlamydia doesn't stain very well. You've got to gym sustain it to get nucleic acids intracellularly, because it's an intracellular bug facultatively. But other than those 2, your UTIs, you understand at this point, there's some gram-negative enterics like E. coli, that's a lactose fermenter without oxidase or urease. All these others have oxidase or urease. Staph saprophyticus, that's urease positive, gram positive. And then Proteus, Klebsiella, Enterococcus, Proteus right there. You've got a urease in that one as well. It's got swarming motility. And Klebsiella is going to be lactase positive. So you're going to plate it on McConkey's. It's going to ferment lactose. And it's also got urease. So that's acute prostatitis. Patient shows up, man, I've got a lot of pain right in between my legs. Oh, let's do a workup. You got acute prostatitis. Easy. Chronic bacterial prostatitis is what happens when you just get acute prostatitis again and again and again, because antibiotics don't really penetrate the prostate gland to as much as we'd like them to. And what antibiotics do we use for these bugs? TMP SMX is way up there. Something like ceftriaxone, cephalosporin is also a good choice for some gram-negative and positive coverage. So if you don't wipe out the bug the first time, it can stick around and you can get prostatitis again and again and again, and that's chronic bacterial. But then we get to chronic non-bacterial prostatitis. Again, this is the majority category here, and it's going to be culture negative. And then you got a 4th category that's very minor. So how do we diagnose this? Really good image here. You can look at the picture and understand everything that you need to from it. You're going to get 4 fluid samples. I would say urine samples, but this EPS sample that you're taking is not a urine sample. It's just a prostatic secretion sample that you collect in a vial or jar. So this is a pretty poor test from the patient standpoint, all things considered, because what you got to do is, well, not only is it really tough to pee, and not only does it hurt for you to pee, but you got to pee a little bit and then stop, and then hold it, and then wait for the doc to switch out the jars, right? And then you got to pee a little bit more and then stop. And then, to add insult to injury, doc's going to stick his finger up your butt, and then he's going to wiggle that prostate and get some juice out of it. And then he's going to ask you to pee one more time. So, my friends, if you've ever peed and then just tried to hold it, I don't know if you did that when you're like a kid or like 10 to see what it's like, oh yeah, I'll just stop peeing. It's like, it kind of sucks. It's really frustrating because like when you start, you want to just keep going, you know? So having to hold your pee for that long, patient doesn't like it. If you ever have to perform this exam, please just get it over with in a very timely manner for their sake. Now, this EPS shot right here, this is our money shot because as you can tell, you are actually squeezing the prostate like you're juicing an orange. And so those secretions are going to pop right out the tip of the urethra. You'll catch them in a jar and you'll culture that. And then you will also culture the very last urine specimen that you get. I think it's the last one. No, you're going to culture the second urine specimen that you take right before you milk the prostate. So between the urine and the prostatic fluids, if you find bacteria, you're going to call it bacterial. If you don't, maybe you do it again. I don't know. So this test is called the Mears-Stamey test. And it's gold standard, but it is falling out of favor because it is difficult and time-consuming to perform. It's expensive, and it's believed to have minimal impact on approaches to treatment. Again, if you have prostatitis, if you have urethritis, what's the difference? You know, you're throwing the same drug at it 10 times out of 10. So really, it's for billing purposes. You want to be accurate with that. But the presence of prostate-specific antigen, if it's elevated in the blood, that can tell you, oh, this is a prostatitis versus a regular UTI. Because PSA is a prostate-specific antigen is a protein that's released by cells of the prostate, and the amount of it that's released is a function of the number of cells in the prostate times the blood flow through the prostate. And so if you're in an edematous, inflammatory state, you can imagine that, well, that's a boggy prostate on physical exam. And so that because there's so much fluid around these cells, there's more surface area for PSA to diffuse out of cells and into the liquid around them. And so there's more in the blood by default. So an elevated PSA can help you make the prostatitis diagnosis. Increased white blood cells in the prostatic secretion, or VB3. I thought it was VB3, you know, I'm thinking it's VB3, but this chart right here says VB2 specimen, voided bladder 2. But then the paragraph down here is saying voided bladder 3. So I don't know. Maybe you just culture the whole thing. You culture 2, 3, and EPS. But you don't got to know that for the exam because they're going to tell that to you in the questions, Tim. So let's chop and dice up these categories. Acute bacterial, most common cause, E. coli. Another very common cause in younger men is chlamydia, common sexually transmitted disease. What does it look like? Well, because it's acute, you see neutrophils. And what do neutrophils like to do? They like to get into the lumen of a vessel, whether it's a gland or another gland. And they like to make abscesses. They like to just have a powwow. And a bunch of neutrophils in one place. Well, what do neutrophils do? They kind of empty out a bunch of lytic, proteolytic enzymes. You know, they generate a lot of radical oxidative species to mediate pathogen killing. And so by doing that, they kind of just kill everything in the vicinity and it melts. And that's an abscess, is just a collection of pus, which is dead neutrophils. And on the right side here, we've got a chronic bacterial prostatitis, and you can tell there are a ton of lymphocytes in this right-hand image surrounding a pretty crowded prostate acinar, which is just the lumen of a gland. So most cases of prostatitis occur around the periphery of the prostate, which is where cancers of the prostate also occur. Clinically, patients will have a fever, maybe some acute phase proteins in the blood, because this is an infection after all. Low back and GU pain, possibly while urinating. Urinary frequency and urgency is also common because the prostate sits right next right underneath the bladder. And recall that the trigone of the bladder is the part of the bladder with a very sensitive innervation, and it's going to tell your brain when you need to urinate. And so because the trigone is literally right on top of the prostate, they're next door neighbors. When that prostate gets big and swells up, it presses on the trigone, and that tells your brain you need to pee, even if you have, like, I don't know, 100 mils in your bladder. And also obstruction may result depending on where the inflammation is relative to the passage of the urethra through the center of the prostate. Whenever you palpate the prostate on a digital rectal, it will have a boggy texture, and that's indicative of edema. And why is the edema? Why is the fluid in the prostate? Because there's bacteria in the prostate that are making a lot of inflammatory cytokines that are going to cause an exudate, which is just vascular permeability, not a transidate. So one of the reasons why we no longer like as much this Mears-Stamey test is because when you put your finger up there and massage the prostate, there's a slight risk of a transient bacteremia, and we don't like bacteremia. No, why? Because that can go around and cause clots in other parts of the body, that can cause an infection elsewhere in the body, that could even cause an endocarditis if it's the correct organism. Again, PSA levels are elevated to help you make the diagnosis, but this is largely based on presentation and symptoms. An abscess will develop in a minority of acute prostatitis cases, and that's just a function of neutrophil response. More symptoms here: backache, sweating, tiredness, and urinary urgency. You know what to do. Chronic bacterial prostatitis is just recurrent acute prostatitis. So here it is again, a positive bacterial culture in the EPS sample or the VB3 sample. So because I'm saying that twice, I'm saying get this weak chart out of here. We don't want that chart. We're going to take the EPS jar and we're going to take the VB3 jar, the thirded voided bladder, and we're going to culture both those. Patients have recurrent UTIs. They just keep coming back, recurrent voiding symptoms. The morbidity associated with chronic prostatitis is considerable. And so mortality means odds that you die of the disease, but then morbidity refers to, of all the patients with the disease, how many of them are experiencing the symptoms. So what that sentence says is that out of everyone with chronic bacterial prostatitis, the majority of them are presenting symptomatic. So bottom of page 6, the 4-glass Mears-Stamey test must be performed for precise diagnosis. And what that's telling you is that there's an ICD-10 code for prostatitis, and so you need to do this for billing purposes. The prostatic secretion, when it's culture positive, confirms that the infection is in the prostate gland. It doesn't exclude the fact that it's in the urethra, but it tells you it's in the prostate. And finally, here's a sentence saying that the EPS prostatic fluid sample and the third voided bladder specimen have a 10 times greater chance to culture bacteria than the VB1 and the VB2. So if they ask you which one do you sample, you know, EPS number 1, VB3 number 2. Lymphocytes, it's chronic. What are the causative agents? Whatever the dude had the first time, most likely, whether E. coli or if he was cathed up, Klebsiella or Staph saprophyticus, and then Proteus, another common GU bug in hospitals. Don't forget chlamydia. In many cases, it's impossible to eradicate the pathogens associated with chronic infection with antimicrobial therapy. All that the therapy accomplishes is growth inhibition of the bacteria residing in the prostate. Some patients have immediate relapse of symptoms as soon as antibiotics are discontinued. That's it. So chronic pelvic pain syndrome is culture-negative chronic prostatitis. Unexplained GU pain in men associated with irritative voiding symptoms. And it's got 2 subcategories. And category 3A means there's inflammatory response. There's immune cells within the samples that you get in the EPS and the VB3 jars. And then category 3B means that when you culture it, you don't even see immune cells. When you look at the urine, you don't see any leukocytes. It's got to go on for at least 3 months for you to be able to make the diagnosis of type 3 prostatitis, chronic pelvic pain syndrome. And the reason why it may present with a lot of pain is because there's a lot of nerve fibers running down into the prostate glands that mediate pain. And so when the prostate expands, it's going to press on these fibers and activate them essentially. And remember that your ascending pain fibers decussate as soon as they get in the spinal cord, then they run up the spinothalamic tract contralaterally and synapse in the thalamus. Now, we give patients with non-bacterial prostatitis antibiotics. Why? I don't know. Money? Like safety? Sure. Throw them some TMP-SMX. Sulfonamides, quinolones, and macrolides are the most commonly used antibiotics. So fluoroquinolones, what's that? That's like Cipro, levofloxacin, and then macrolides, that's going to be like a erythromycin, azithromycin. Good gram-negative coverage on those. Finally, asymptomatic inflammatory prostatitis. This is an incidental diagnosis done on biopsy whenever dude's got a PSA of like 8 and he's asymptomatic, but you're going to biopsy it anyway because the PSA is so high. And then it comes back and you see some inflammation in the prostate. And so this is just like 3, but guy doesn't have any symptoms. So prognosis. For categories 1 and 2, the bacterial prostatitis, you're going to throw a lot of antibiotics at them, but if that doesn't work, you might have to open up the prostate and drain an abscess. Now, for the non-bacterial prostatitis, you can throw an alpha blocker in there, and you can throw an NSAID at them, and that alone might be enough to get some remission symptoms. BPH, benign prostatic hyperplasia. Number one important thing to know is that this is not a precancerous lesion. There is no correlation between BPH and prostate cancer. Prostate basics there. Not going to dig into that. Most benign prostatic hyperplasia arises in the transition zone, which is blue on this graphic here. It's not the front, not the back, not the periphery, just kind of the middle. And it's slightly anterior, as you can tell by this astounding 3D graphic. Wow, somebody did a great job on that. So if this is a slice of the prostate, an axial slice, where you would expect to see hyperplasia is right around here, close to the middle. And hyperplasia, there's a sequence of events. First, you get some micronodular proliferation, kind of reminiscent of cirrhosis. And then later on, maybe a decade or 2 down the line, those nodules start to expand in size. So first you get the nodules, kind of like seeding, and then the nodules blow up. That's the timeline. So hypertrophy is incorrect, because what's hypertrophy? An increase in size of an individual cell. But what's hyperplasia? An increase in number of cells within a tissue. Histologically, what's important for you to know is that the chief component of BPH is stromal, not epithelial in origin. And so here's some pure stromal hyperplasia on the right, and there's a lot of edema in there. Why is there edema in there? Because when we say stromal, we're referring to connective tissue that holds other tissues together. So how do tissues hold other tissues together? Well, the cells that do that are fibroblasts, and what they do is they secrete a lot of collagen into the extracellular matrix, and that grabs onto cells and gives them ground to stand on 3-dimensionally. So the reason you see lots of edema in this sample is because there's a lot of collagen floating around in the extracellular matrix. It's acellular. On the left here, a good reference of this microcystic glandular appearance, specifically right here in the lower left quadrant. A normal gland is maybe something that you see on the right here that I put in a square, but then These down here in the lower left are blown up and dilated and tortuous in appearance. That's your hyperplastic glands. Here in the SDL, the hyperplastic nodules are comprised of stromal components and to a lesser degree epithelial cells in about a 4.6 to 1 ratio. So I definitely think that that'll be a question on either clin med or pathology. The size of the prostate does not correlate with the degree of obstruction. So what does correlate with the degree of obstruction? Well, we take it back up and look at a gross slice of a prostate. What determines the degree of obstruction is going to be how close those nodules are to the urethra that's passing through the prostate. So if you have a ton of nodules, but they're all out here, that's nowhere close to the urethra. You can still pee normally, so you'll be asymptomatic. But even if you have a little bit of nodules, if they're in the right place, there's your compressive symptoms. Then we've got a good section talking about the bladder's adaptive stress response to chronic obstruction. And this is a really good time to remind you what the heart does in response to stress. The bladder can hypertrophy. And that's going to be a pressure overload response. Remember that in the heart, when you have to pump against a large afterload, you're going to get concentric hypertrophy. Concentric meaning towards the center. And so what that means is that myocytes are going to replicate in parallel. That means one next to each other. And so that's going to thicken the wall of the heart or the bladder in either case to allow you to push fluid out of it against a higher afterload. And so a skinny urethral lumen represents an afterload. You can treat it the exact same way. Now, decreased detrusor contractility, that's the muscle of the bladder. You might see decreased contractility, and alongside it, you're going to see a thin wall bladder in this case. And so that's going to be an adaptive response to chronic volume overload, which is exactly what happens in the heart when you got a preload problem. Maybe you're not controlling your blood pressure, right? Maybe you've got a huge fluid volume and your heart has to dilate to accommodate the large volume that's hitting it with every single stroke. So the muscular response to a volume overload is to expand in series rather than in parallel. And so in series is like 1, then 2, then 3, then 4 myocytes. But then in parallel would be like 4 myocytes stacked up next to each other like that. So that's a big difference there. Important that we want to treat BPH with alpha-1 antagonists because alpha-1 mediates smooth muscle contractility, and there's a lot of smooth muscle in the urethra. So you want the urethra to be wide open, as wide as it can get if somebody's got a prostatic compression problem. So you're going to throw something like terazosin at them, and it's got side effects of orthostatic hypertension, hypotension, and I think bradycardia, tachycardia, bradycardia. One of those two. Let me think about that actually. So if you're dilating everything, then you're going to return well, if you got orthostatic, then that means less blood's going back to the heart. So I think you get tachycardic in response to that. One more thing. Your alpha-1 receptor is a GQ protein. Your alpha-2 is a GI, and then both your beta-adrenergic receptors are GS proteins. They kind of like to ask about that. Clinical presentation, bringing up this terminology, lower urinary tract symptoms. That's just what we call dysfunctional voiding, plus prostate gland enlargement. So there's a code for that. It's BPH with lower urinary tract symptoms. That's why this is in there. And then it lists a bunch of them. And you don't really need to know them by heart. You know, it's like, okay, you got problems peeing. Okay, LUTS, check. But it is important for you to know that when a patient comes in with some of these symptoms, you've got a differential. Okay, you've got a lot of different things that you're thinking about at first. You're not going to go straight to the prostate. So what's in that differential? Well, good paragraph here lays it out. Neurogenic bladder, bladder cancer, cystitis, stones, prostatitis, prostate cancer, urethral strictures, STD, a lot of different things. The digital rectal exam, this one is interesting. So whenever we talk to other practitioners, we can communicate our prostatic findings based on the number of fingers wide that the prostate was on examination. I just want to bring this up to tell you, you're not sticking 3 fingers up the dude's butt to get to his prostate. You're not sticking 4 fingers up. That's not what it means. Like, I think it's definitely 3 finger breadths wide. Like, can I get a 4th? It's like, no. You're only putting 1 finger up there, and then you're just moving it and using your spatial mind to be able to say, okay, that's 1 finger, that's 2 fingers, that's 3 fingers. Is that a 4? Nah, not quite. That's a 3-finger hyperplasia. Glad we cleared that up. So BPH is going to hit almost every male on the planet if you live long enough. And again, the diagnosis is super easy. Question is, what do you do about it? You throw an alpha blocker at them. Androgens is really a discussion for prostate cancer. Let's see. My PDF is being whacked. Let me reopen it. There we go. Yeah, androgens is a good lead into prostate cancer because of the influence of dihydrotestosterone on the prostate. So what's going on essentially is that in a hyperplastic prostate, we think that there is some gain of androgen receptor function over time within cells of the prostate, which is going to make them hyperreactive to androgen stimulation. And that's going to make them divide. That's it. Now we'll go back up and walk through that one by one. Testosterone gets converted into dihydrotestosterone by 5-alpha reductase. And a reductase is going to throw a hydrogen at a double bond and saturate it. So now you have a single bond between 2 carbons. Now, the concentration of dihydrotestosterone is not higher in the prostates of men with BPH than it is in those without BPH. So the concentrations of this steroid itself are not responsible for prostatic hyperplasia. But we think that there might be a gain of function, again, in the androgen receptor that's leading to more cell growth in response to DHT than there should be. And we think this because we've looked at it and we've discovered that prostates of men with BPH express the androgen receptor at a much higher concentration than normal prostatic tissue. So, because we understand that cells of the prostate have the 5-alpha reductase enzyme that's necessary to make dihydrotestosterone, and we've observed higher concentrations of the androgen receptor, we understand that these cells, let's say this is a prostate cell, it's making dihydrotestosterone inside it, and then it's spitting it out into the outside world. So the DHT goes outside the cell, and where does it go? It just goes to the neighboring cell and it works on that. And so then that cell binds DHT and divides, just makes a copy of itself, right? So this is local signaling. You could say autocrine and paracrine signaling. This is not an endocrine process particularly. So the reason why stromal cells get involved first is because when the androgen receptor is activated, one of the things that it makes the most of is fibroblastic growth factor and stromal connective tissue, fibroblastic cells. That's it. So probably a question from that section. And finally, We can use alpha-1 antagonists for symptomatic control of urinary retention and urgency, but to treat the cause of the disease, a better drug for that is the 5-alpha reductase inhibitor. It's called finasteride. And this is an important drug. They want you to know the drug because, again, they're going to ask you more so about the treatment and the management of these patients rather than the diagnosis. It's an easy diagnosis to make. Patient's got micronodules in his prostate and they're not stony or hard. It's not cancer, it's BPH. So these 5-alpha reductase inhibitors are going to prevent testosterone from transforming into DIHYDROTESTOSTERONE. So that's very good for the prostate. That means it'll stop making growth factors. And as a bonus, you'll grow a little bit more hair because you also express the enzyme 5-alpha reductase, if you're a guy, in your skin peripherally. And so male pattern baldness is testosterone mediated. And if you block the conversion of T to DHT, well, DHT is a much stronger version of testosterone. So it'll slow the rate at which you go bald. And finally, please call it baldness. Don't ever call it hair loss. Baldness has a way better connotation because it's like, yes, you might have lost some hair, but you've gained some baldness along the way. It's always spin it for your patients. Put it in the best light that you can and hope that they do the same for you. So that's BPH. Let's go ahead and go straight into prostate cancer. You want to understand the big difference between carcinoma and BPH at the cellular level is that in cancer, in precancerous lesions, the nucleus of the cell is all sorts of screwed up. It's going to be large, hyperpigmented, hyperchromatic, atypical, mitotic, however you want to say it, it's going to have a weird nucleus. And BPH, again, mostly fibroblasts involved there, but prostate carcinomas tend to be adenocarcinomas, so they're of glandular origin. So glandular cells, not fibroblasts, and they have big old nuclei. That's what's going on. And questions from this SDL are really going to target, again, the management of these patients. Can you take the severity of the cancer that they will give you in the question and figure out what to do with this patient? Because it's not the same. And let's get into the Gleason patterns and hit that first. So this section, staging, we don't get staging questions, yo. That is not a step one thing. They do not expect a second to third year medical student to be able to recite the stages of prostate carcinoma. So you can gloss over that if you want. Grading, my take is you're not going to have to pick a grade 2 versus a grade 3 out of a crowd on a slide, but you're going to have to understand the words that go to each grade and the gradations in between each category, so that if they give you, here are the 2 most predominant samples, well, then you can derive the Gleason score and figure out how you're going to treat the patient. So technicalities out of the way. Got off track. Let me get back to the beginning. Incidence of prostate cancer dramatically rose in the 90s, concomitant with increased PSA testing. And so we were catching them left and right and we were treating them, but then we realized, wow, a whole lot of these don't even need to be treated. What are the risk factors for prostate cancer? Age is the #1 risk factor. If you're Black, you're more likely to get it. And there are a few genes that will predispose you to this: BRCA1 and BRCA2, homeobox B13, and Lynch syndrome with its MLH, MSH mismatch repair genes. A couple more risk factors: diet high in animal fat and low in vegetables. Smoking, definitely. There they are. You know what to do with those. Precancerous lesions, the PIN versus the ASAP. Prostatic intraepithelial neoplasia. Understand before we focus on what it looks like, if you get prostatic intraepithelial neoplasia in a question, you're just going to monitor this patient's PSA. You're not going to treat this thing. You're not going to give them a drug. You're not going to take their prostate out. You're not even going to rebiopsy in most cases. But if you get ASAP, like Rocky, atypical small acinar proliferation, this has a higher risk of becoming cancer. So you will rebiopsy the ASAP in 3 to 6 months afterwards to see if it has progressed. So what do they look like? Really the same thing, to be honest. I'm not going to say anything about those. Pathology. Carcinoma of the prostate arises in the peripheral zone. That'll be a gimme layup question somewhere in your career, in your tenure as a student. So just put the ball in the hoop. Peripheral zone, prostate cancer. On the right, we're checking out here in the middle of this needle core biopsy is a cancerous specimen. And with prostate cancer, glands get smaller instead of bigger. And then they get bigger when they get really, really high grade. But first they get smaller. And so these glands in the middle here are definitively smaller than those surrounding it. Like right here, that's a normal gland. Right here, that's a normal looking gland. But then these dudes right here in the middle, those are precancerous. And the Gleason score of grading prostate cancers is based on architecture. So you really don't have to look at nuclear changes as much as you do architecture. So you just zoom out a little bit, blur your vision up, and look at the slightly bigger picture. Important to know is that we want to stain these tissues for cytokeratin because monitoring basal cells is very important from telling a precancerous lesion from a cancerous lesion. Basal cell markers, such as cytokeratin, constitute the immunohistochemical cornerstone of prostate diagnostics. That's important. Prostate cancers grow up, and then they like to spread through lymphatics up to the periaortic lymph nodes, and they can get all the way up and into the subclavian and into Virchow's node. But sometimes they get into the bloodstream. And when they do, they cause blastic metastases. What that means is that you take an X-ray and you've got some little spheres in some bones that just light up because they're really, really laying down bone. Now, when you see blastic metastasis, prostate cancer's got to be the first thing on your list if you're looking at a dude. A couple other things that can cause it very rarely are breast and certain lung cancers. Prostate's way up there. And a good serum marker for blastic metastasis is alkaline phosphatase. You remember that ALP is really made 2 places in the body at 2 times. First of all, it's produced by cells lining the bile duct, right? And so ALP and GGT, that's our biliary panel. And then it's also produced by osteoblasts, and it's going to encourage bone formation. So you can take ALP and monitor how much bone is being laid down. Another marker, thing we can splash on a slide to make it glow, alpha methylacyl-CoA racemase. Cool, thanks. So let's talk about the grading. This is the heart of this lecture. When you biopsy a prostate, you're going to take 12 different biopsies. And then you're going to take these biopsies, and a pathologist is going to look at every single one and put a number to the highest grade tumor or cell population that they detect within this biopsy. So after you do that for all 12, you look at them and you say, this is the pattern of this biopsy. Then you take the first and the second most prevalent patterns, and each pattern gets a number, and then you add those numbers together, and that's your Gleason score. So one more time, you take 12 biopsies, you give all 12 of them a number, you say, what's my most common number? What's my second most common number? You add those, that's the Gleason score. So pictures throughout this are telling you what gets a 1, what gets a Gleason 3, what gets a Gleason 5. So let's break that down because you got to know that for our exams. Gleason pattern 1 is well differentiated. Gleason pattern 2 is basically the same thing, and I would bet my left nut they're not going to ask you a 1 versus a 2. Gleason pattern 3 starts to infiltrate into surrounding tissue. Gleason pattern 4, you start to see fusion of acini leading to a cribiform pattern. And cribiform essentially means Swiss cheese. It's got holes all up in it. Like this right here in the middle of this picture on the left, that's what cribiform means. This too. And finally, a grade 5 Gleason means glands are virtually non-existent, tubules and lumens are virtually non-existent, and you just see a sheet of cells. So the 3 versus the 4 versus the 5, there are some pretty big steps in between. So I could see us getting asked that on a question or two. But it's not only important to know what the grades are, it's important to know what do you do with them. So if the patient has a grade that's lower than an 8, you're really not in a rush to take the prostate out. If it's an 8 or higher, you're like, all right, let's consider a radical prostatectomy, and then let's look for regional metastases. Especially if it's a 10, you know, you're like, we got to get this thing out. We got to do a lymph node biopsy. But if a guy's got a grade 3 Gleason, you know, that would mean that the most prevalent grade within the biopsies taken was a 1 or a 2. And then the second most prevalent was the other number. Saw a practice question about this. A really old dude had a grade 3 Gleason. They said he had a grade 1, 2 adenocarcinoma in the prostate. So that means a grade 3. Add them together. What's the treatment? And so the options were like radical prostatectomy, begin anti-androgenic therapy, put him on an alpha blocker, like monitor, and no farther therapy. And so that was the answer, actually, no farther therapy, because this guy's really old anyways. He's got a very low-grade prostate cancer. It's not doing nothing. Just let it sit there. And that's the sort of question that I can see us getting asked. Again, we're going to have multiple tests on the prostate. Path included. So the genetics. I'm really looking at these first 3. They list like 6 or 7, but they're not going to ask you about something that's that far down on the list. They want to ask you about the high yield ones. So GSTP1 gene is mutated. It's a tumor suppressor gene. It's got a loss of function in over 90% of prostate carcinomas. And man, I feel like such a tool right now, because it's like they don't even give you the grace of telling you the name of the gene. They're just like, here is GSTP. And right now I'm just like, man, yeah, I'm a medical student. I'm just memorizing letters and numbers, you know. So after that, it's telomerase, which is present in 90% of prostate cancers. And this CMYC oncogene is going to be mutated in more than 80%. So on the exam Tuesday, that's going to be one of the answers if they ask that question. How does prostate cancer present? Well, typically we're going to get an inkling of an idea that it's there because of PSA levels, because we do start screening for those, especially if patients have family history. Normal PSAs are going to be 2 or less, I would say. And it starts getting up into 4, 6, 8, 10 territory. Then you're going to start thinking about a biopsy. The PSA value that we care about is its velocity, which is rate of change over time. Because if it's kind of elevated, but it stays the same, well, it just means dude's got a big prostate. It's not getting any bigger. But if it's going up, we're saying, wow, there's some active growth going on in there. We need to figure out if this is BPH or cancer. So you digital rectal, and that's going to be the gold standard diagnostic. And you see if it's any firm nodules up in there. And we've practiced on the model by now. We know what that feels like. Other characteristics of prostate cancer. Look for that bone pain. It's very rare that it does metastasize to the bone, but when it does, it's going to cause bone growth. It's a blastic metastasis. Section talking about diagnosis, just understand you're taking 12 different biopsies, and then you're giving a grade to each one, and then you're taking the 2 most frequent numbers and adding them together, and that's your Gleason score. Treatment, big paragraph here. If they've got a big Gleason score, like an 8, that means like 4 and 4 were the most prevalent patterns, or 4 and 5, you're going to want to take the prostate out. And then you're going to want to follow them up for a long, long time and probably even do some radiation therapy locally to make sure all the lymph nodes are clean. But if the patient has a Gleason 3 or 4, or if they're a very old patient, then you're just going to monitor this thing really. Active surveillance. That means take PSA every 3 to 6 months, take a biopsy every half year or a year, and we'll see where it goes, because not all of these kill people. Finally, metastatic prostate carcinoma. You have to throw some androgen deprivation therapy at it to try to shut it down, because the androgen receptor getting activated, as we just looked at in that last SDL, when the androgen receptor activates, prostate tissue makes growth factors, and that just tumor cells feed off that. So a final section, unusual types of prostate malignancies. I really hope that we get thrown a question on this because they're very easy. Ductal adenocarcinoma. A ductal adenocarcinoma involving the central ducts of the glands. So these are branched glands, right? And so you've got multiple terminal acini feeding into a duct, just as you do in your pancreas. And so run-of-the-mill prostate cancer starts off down here in the terminal cells. But then a ductal adenocarcinoma is going to be when one of these ductal cells pops up and starts getting cancerous. And remember, the ductal cell is the chief neoplastic cell in the pancreas. So what do these look like? You see a cribiform pattern, Swiss cheese kind of. You see pseudostratified epithelium. That's very particular, and you see it here on the left. So big, tall columnar epithelium. Tall columnar epithelium, literally. Like, that's all you got to say, really, because these other prostate cancers, you're looking at them, they stay pretty cuboidal throughout. So columnar, one more time, is the name of the game for the ductal adenocarcinoma. You've got a mucinous, also known as a colloid carcinoma, and that is just a 82-mile-an-hour fastball. You've got a signet ring carcinoma. Probably never going to see one of these in real life, but what organ are you going to see it in? The stomach, definitely. Like 10% of gastric cancers are these signet ring cancers, and that's the one that gives you the leather water bottle stomach, you know, where the whole stomach is just turned to collagen, basically. Then you can see a small cell carcinoma with small round blue cells that are going to stain for all that good stuff, neuroenolase, chromogranin, you know it. You might see a squamous cell carcinoma. So what do you see there? Keratin pearls. What's the patient probably got? Schistosomiasis. Likes to get into the bladder. It's a blood fluke. What's next to the bladder? The prostate. There you go. Urothelial carcinoma is going to have umbrella cells, and they're going to be big and, you know, like open an umbrella. That's a urothelial cell. And that's actually going to be more tied to the urethra than it is the prostate. Finally, you might see a sarcoma, which is a tissue of mesothelial origin. It's a malignant cancer of mesothelial origin, and indicating its cell layer of origin. You see spindle-shaped cells, and there are two variants here, and one of them is basically, it doesn't look that bad. We can't quite call it a sarcoma yet. And then the other one's a full-blown invasive sarcoma that is doing bad things with atypical nuclei and scattered mitoses. So that's prostate cancer. In conclusion, expecting 2 questions probably on Gleason patterns, expecting 1 question on unusual prostate malignancies, expecting a question on what do you do after you diagnose this patient, whether it's a low or a high Gleason score, and then probably a question on the early stuff in this SDL, such as the risk factors and the genes involved with prostate cancer and or the precancerous lesions. Let me break down this precancerous lesion section one more time and see if I can take anything out of it. So we're going to read it slowly, because I'm like, what's the difference between a PIN and an ASAP? Prostatic intraepithelial neoplasia is confined to pre-existing prostatic ducts or acini. High-grade PIN, you can have a low-grade PIN. High-grade just means that there's a little bit more atypia. Now, see, low-grade PIN has no clinical significance, And men with a low-grade PIN do not even need a repeat biopsy. You just leave it there because it's not going to transform into a cancer. But then again, this atypical small acinar proliferation can transform into a cancer. So I suppose this is what I remember now. A small focus of atypical glands, typically 2 to 3. That, to me, is what's going to make the difference between a PIN and an ASAP. So, I mean, it's a speck. It is a very small lesion. But the fact that it is so small tells you that it could be cancer in a very early stage. Whereas if it's bigger and it involves more than 2 or 3 or 4 glands, you're like, all right, this thing is yay big and it's not a cancer yet. It's never going to become a cancer. So that makes sense to me. I hope it makes sense to you too.